So you can keep your questions after my presentation and keep them easy. Now, I don't like difficult questions. So, so I will give you a brief overview. Nothing very great. My presentation will be simpler, and you will. You see, we all know that it is the anti. You see, as a student, I had the impression that it is anti-Holt cell disease. You know, it is classified as anterior Holt cell disease. So the training in during MBBS and later on was that is the spinal cord has anti-Holt cells and they are primarily affected, and we generally have upper limb or lower limb involvement. I mean, that is the impression. But you know, actually, the motor neurons are actually lying in the cerebral cortex also, and then it is going to the medulla and then to spinal cord and then to the muscle through nerves. So the regeneration can be through anti-Horn cells, through the motor neurons rather than anti-Horn cells. So that we must keep that concept in mind, that it may be motor cortex which may also be affected. And you know that it may be a combination of upper motor and lower motor neuron, which may have a limb or bulbar onset. So if the limb onset and only upper motor neuron is a primary lateral sclerosis. If it is a bulbar involvement and only upper motor involvement, will be pseudobulbar palsy. If it's a lower motor involvement, will be progressive muscle atrophy, and progressive bulbar palsy may be if there is bulbar involvement. And if there is a combination, it will be classical ALS. So this is the spectrum which we should keep in mind. And obviously, it's a very all elementary that lower motor and upper motor neuron signs. Lower motor neuron signs are atrophy, fasciculations, and in thoracic region you will have fasciculations, abdominal and trunk, and in the lumbosacral region you will have leg atrophy and fasciculations, and brainstem you have flaccid dysarthria and tongue atrophy and fasciculations. And upper motor neuron signs are known. They are known as Hoffman signs and negative abdominal reflexes and cross-erector signs and spasticity or spastic tongue, etc. See, these are mentioned here. And we all know that the classical ALS, and then you know what I just said, that primary muscle atrophy, primary lateral sclerosis, and pseudobulbar palsy bulbar onset. And of course, fasciculations are known to be pathological or benign because, as I said, you know, early stage, third year students have also fasciculations and they worry about motor neuron disease. So we are always asked in our exams, MBBS exam, you know, fasciculations, what are fasciculations and what is benign and malignant fasciculations. And the examination answers are shown in this slide, that they are pathological fasciculations are regional or maybe widespread, whereas benign are restricted. Frequency is abundant in pathological and benign are infrequent. Of course, there are upper motor neuron signs of weakness in the pathological, and they will not be. And then EMG will be abnormal in pathological and it will be normal. And so these are very well known, and this is what you will answer and you will pass your exam. And later on, I will tell you the limitation of this information. So the residents who are going for exam, they will answer this and they will be correct answer and no problem. Then, you know, the ALS has a spread. It may be spinal form is more common, and it may be rostrocaudal or it may be contra. It may begin in this cervical region, or upper limb may be affected first and lower limb may be affected later on, or it may start from the lower limb and it may go to the upper limb. So this may be rostrocaudal spread. Then it may start from one side, you know, the Mills variant, and then go to the other side. So it may be bulbar involvement, 20 to 30% have swallowing or speech abnormalities. Axial involvement will lead to abdominal protuberances and head drop sign, which everybody knows. And sometimes there will be respiratory involvement in ALS. In fact, I had, for your presentation, I had brought a case presenting with 2 years history of cough and dyspnea, and she came to OPD with severe dyspnea. On examination, you found some reflexes which were just present, pure motor, and swallowing difficulty. And I thought that this was a respiratory variant of ALS, predominantly presenting with respiratory compromise. So I sent her to the lab, to Dr. Jayanti, to do the EMG. And I wanted to take the EMG. But by the time I could come, you know, she got respiratory compromise and had to be intubated. So now EMG could not be done. What I'm trying to say that there may be a variety of ALS which may be only respiratory. We had discussed a case of myasthenia with only respiratory complications. Similarly, ALS can also be as focal as to present as only as respiratory. Maybe if you do EMG, we can get some denervation in other muscles, I don't know. But in this patient, we had clinical evidence of only respiratory involved. Patient was walking, patient was eating, had some difficulty in swallowing, this sick, and X-ray is normal, and EMG could not be done. So just keep in mind that there may be a variance. Then, of course, we may have dementia in these patients. This is a little busy slide, but then it tells you most of the things. But what I have been saying, with the classical ALS, there may be upper motor neuron, bulbar involvement, upper limb and lower limb, upper motor, similar in the lower, and there may be FTD, there is frontotemporal dementia, and it may begin inferior extremity or in bulbar region. Then, we have progressive bulbar palsy, we have a respiratory involvement, we have progressive muscle atrophy, we may have primary lateral sclerosis, which I will discuss again. Then you have pseudoneurotic. Patient presents like a neuropathy, pure motor neuropathy. Patient with only limb weakness, upper limb and lower limb, looks like a neuropathy. And you do EMG, you find that it is a progressive muscle atrophy and it's an anti-horn cell involvement. We may have hemiplegic variant in which you have discrete one-sided involvement and later on the other side is involved. You may have flail arm syndrome or flail leg syndrome. Patient presenting like brachial neuritis only in the upper limb and walking and sometimes lower limb involvement. Patient may present head drop. Of course, there may be other features. And then you have FTD ALS combination. So this is the whole spectrum. And so we have to be mentally prepared to see this variation. And there may be one thing may be prominent, but there may be other involvements as well. Primary lateral sclerosis is a rare diagnosis. It occurs in 4%. If you see 100 cases of ALS, you'll see four these cases. They occurs in advanced stage. Average survival is 10 to more than 10 years in 70%. So this is a very slower progression, and these patients live long enough. They may have urgency of urine, swallowing difficulty, and it maintains power in the proximal muscle. They may be walking quite well. And we should not diagnose it till 4 years of symptoms have been observed, because otherwise this may lead to errors. So this is a very slow progressing disease and is a pure motor lower limb spasticity. Looks like laterism in a way, which I will discuss again. Proximal muscle atrophy, again, this is a rare variant, 3%. Upper motor, it's a controversial entity. Some people think there are some upper motor neuron signs which have not been documented or seen, and therefore people call them just anti-horn cell involvement restricted to anti-horn cell, and they will have weakness, atrophy, fasciculations, hyporeflexia, and this is another patient. We all know that this patient of bulbar weakness, trunk atrophy, and he got limb weakness and atrophy. So this is if all three regions are affected, then it is a definite. If two regions are affected, it is probable, and if one region is affected, it is possible. This we all know. 25% of patients at a stage, could not be diagnosed based on these criteria. These was older criteria, and there were need for getting more cases for trials. Therefore, the criteria have been modified, and now the lab-supported criteria have been added up so as to catch more cases. Firing rate has been added up so that you can diagnose these cases, more of these cases, and the patient could be recruited in sufficient numbers. So the same thing here, that there were LS Coriel criteria, and then firing rate was included. They include the diagnostic yield. Then LI house criteria, lab supported probable ALS was added, and then electrodiagnostic, radiology, and lab may result in earlier diagnosis by 9 to 12 months. So these laboratory supported criteria have helped to pick up these cases at an early stage and in larger numbers. Why a patient with ALS is referred? Number one, patient's relative demand, that whether it's ALS or not. And then we, as a physician, we want to rule out ALS mimics. There will be something curable, and therefore you want to be sure that you're not missing a curable diagnosis. Of course, for the therapeutic trial and early diagnosis, and we must diagnose it early if the efficacy of drug is to be tried. If a patient is a severely atrophic and bulbar palsy and respiratory compromise, he's not suitable for a drug trial. So we have to see these cases at an early stage, diagnose them confidently so that new drugs can be tried in these cases. The problem with the classification and diagnosis is that the diagnosis is based on relative number of clinical signs rather than patient has ALS or not. You have a whole lot of upper motor, lower motor neuron signs, and then on that basis, we presume that it is ALS. There's no biological test for ALS at the moment except for some small number of genetic cases. And the second problem is that ALS patients don't progress in a systematic manner. I mean, this is not an orderly manner in which you'll progress. It may be lower limb, and then there may be bulbar involvement. It may be bulbar involvement and the upper limb involvement. So there's a, not a predictable pattern of progression, and therefore again there is a problem in the diagnosis. And for essentially, the ALS is diagnosed on clinical examination, pure motor weakness, upper motor and lower motor neuron signs. And then you do the needle EMG and nerve conduction studies and do RNS study to make the story complete. And of course, same thing again, I have said that exclude the treatable mimics and confirm the diagnosis. Upper motor neuron involvement is mainly clinical. There is no neurophysiological test which we can do in upper motor neuron evaluation except for Hirayama disease. We looked at H reflex, but H reflex, we looked at the inhibition of H reflex. Normally, if you give a vibrator or you give an exercise, then the H reflex size will go down. But if it doesn't go down, then there is a lack of inhibition. And therefore, that study we did for lower limb spasticity in lower limb hyperreflexia and Hirayama disease and found it to be negative. But otherwise, upper motor neuron signs are clinically elicited. For lower motor neuron, we have to see check normal sensory conduction and we'll look at the denervation renervation. Start with the weak muscle. Weakest muscle should be examined first because this is likely to give you maximum information. Now, this is an important diagram. It shows you that the motor neurons in the brain stem, and the spinal cord are affected. Now, what is the number of muscles you require in each segment? For brain stem, one muscle is okay. I mean, there are not many muscles in brainstem, innervated muscles, which you can do EMG. So we can do facial muscles, or we can do masseter, or we can do, tongue. So, or we can look at even trapezius, which is dual supply. So we can look at sternomastoid. So these things can be done. So if you are getting reliable changes in one muscle, it is okay. For cervical, you need two muscles by different nerves and roots. And then for thoracic, you need again one muscle. And for lumbar, you need two muscles minimum. So these are the minimum numbers. You can increase the number to make your confidence. So this is, of course, this slide also tells you what are the upper motor neuron signs and lower motor neuron signs, which I don't have to repeat. But most important is bulbar brainstem involvement, one muscle, cervical, two, thoracic, one, and lumbar, two muscles are required, innervated by different nerve and roots. Now, this I have told you initially also, this is positive sharp wave and this is fasciculation, and how do they fire and they appear, you all know. Only thing is that EMG changes will come in an ALS patient when 30% or more than 30% of interhorn cells are lost. So when you are getting EMG findings, disease is far advanced, maybe 50% interhorn cells have already been affected, then only we are getting the signs. And the denervation signs are more marked in the weak muscles. So if the hand muscle is weak, you do EMG, you'll find more likely the denervating changes. And the changes will be in grade 1 weakness or grade 2 weakness, we have 90% changes. If grade 3, we may have 50% changes, and grade 5, we will have 24% changes. So it can reveal abnormalities in normal muscles, normal power muscles, but the chances are less. Whereas in a weak muscle, the chances of getting abnormalities is high. The denervation is easier to get in FDI, APB, deltoid, and thoracic paraspinal and tibialis anterior. So these are the easy muscles. When you're looking for fibrillations, remember these muscles: FDI, APB, deltoid, thoracic paraspinal, and TA. It is more difficult in other muscles. You may not find it very easy to muscle in gastrocnemius or maybe sternomastoid. You will not get it so easily because it's difficult to relax. These muscles are easy to relax, and I will show you again. And these are less frequent in vastus lateralis and biceps. I will show you biceps muscle also. You'll see that it is not very easy to get good fast fibrillation potentials in biceps and vastus lateralis. whereas in other muscles you'll find it easier. So you may have this background information, it will be easier to do the EMG. Now this is, I had told you the difference between benign and malignant fasciculations, and we had tell you the differences for answering in examination and passing the examination. But you know, this is studies by Mills, Kerry Mills from London. It was interesting. They looked at 35 ALS patients and 18 patients with benign fasciculations. 35 ALS, 18 benign. And they concluded in this paper in Brain, there was no difference in the benign and malignant fasciculations. So this is all right from common sense. Denervated ALS patients, denervated muscles, you may have large fasciculation with all abnormalities and jitter, etc. But actually, when you look at them in a formal manner by a trained person, then there is no difference. So this is again not for exams, but for those our colleagues who have passed exams and now taking exams. So they can, that is very important. And with progression of ALS, the interfasciculation interval will decrease. So the fasciculations will become faster and more easier to develop, and the duration will increase and area will increase. But that is okay. Then motor unit potentials. Of course, you see when there is a degeneration of the anti-horn cell, then the collateral sprouting occurs, and the duration of motor unit potential will increase. So we'll have large size potentials. Some people call them HALD, high amplitude long duration potentials. Although we don't give much importance to amplitude, but then some people think that large potentials will be high amplitude long duration. So if there are very high amplitude, the duration will be wrong. So amplitude and duration are some way related. So high amplitude long duration motor unit potentials are the evidence of renovation, and they are easy to see. This is another, and you know, the firing rate of the motor unit increases. You see, very interesting. When you do the EMG, there is a loss of anti-horn cells. So there is only 1 or 2 units are firing, but they try to fire at a fast rate to make up for the power. Usually what happens, the lower one is a normal person. What you see when you are increasing the action, the second motor unit is coming. You see, this is one large unit and there is a small unit. So these two are coming. So once you are giving more activity, then one more unit is coming. You apply more power, the third one will come. And in this way, the firing rate does not increase so much. Whereas the motor units come and they, but there are no motor units. So what happens that in ALS, you will find that motor units start firing at faster rate, and there is not compensation by more motor units which are not there because of loss of anti-horn cell. And the second thing is that if there is upper motor neuron involvement, if there is a the inhibitory control is gone, so then the firing rate again goes, the motor units again go down. So in a spastic limb, you will find that there's very few motor units and they're firing at a fast rate. Now, the nerve conduction study, we must, when we do EMG for an ALS patient, we must do nerve conduction study. So we must do one motor with F, one sensory in upper limb and lower limb on, and especially on the affected side. So we must do sensory conduction and motor conduction and look at the F latencies and then go to the EMG examination. It is very important because we do motor conduction, sometimes you will find multifocal motor neuropathy, small amplitudes and become absent conduction and the conduction block, and then you can think of a multifocal motor neuropathy. So it's very important to keep this possibility. Low CMAP amplitude is very important. It can occur in myopathy, but it does not happen in disuse atrophy. So quite often you will find sometimes the amplitude is less and people say it is because of disuse. Please don't consider disuse as an important cause. It is mainly because maybe loss of anti-horn cell or because of the muscles, and therefore, but not because of disuse atrophy. Low CMAP, less than 50%, maybe because of phase cancellation and slowing in same nerve, and the area measurement people think is more important. The problem has been discussed with conduction block. Then power is proportional to CMAP. If there is a very weak muscle, CMAP will be smaller. In mildly affected cases, CMAP may be a little bigger. So that we must remember that the amplitude of CMAP is proportional to the power. And although nerve conduction may be slightly slowed, But by and large, I insist that in ALS, we should consider that the sensory nerve conductions are normal. Although if you want to read papers, there are people who are saying that there may be some slowing of sensory conduction, but I want to avoid this finding, otherwise it will lead to a lot of diagnostic confusion. Although those postgraduates who want to dwell into this area, they can read papers and they will say that there may be dorsal root ganglia involvement and there will be subtle slowing. And in Kennedy syndrome, for example, there may be slowing, although it's anti-horn cell disease. But by and large, I think we should keep this the life straight that sensory conductions are normal in ALS. Sensory symptoms may be there, but sensory conduction abnormalities, we should think it is normal. Now, which muscles to examine? We have to examine minimal number of muscles to get adequate information. Above cervical spine, you can see trapezius, sternomastoid, frontalis masseter, and tongue. So these EMGs one can practice, and if you can relax the patient to see fibrillation and motor units, you will get familiar. Then fibrillations are best seen in weak and atrophic muscles, and this is best to begin from there. Subclinical involvement can be seen in normal muscles, but not very frequently, but sometimes 20 to 30%. We must examine 3 levels or 3 limbs for abnormality of fibs, high amplitude, long duration motor unit potentials, and reduced recruitment. We must examine thoracic paraspinal. Bulbar, we can examine tongue, masseter, and frontalis, which I will show you. And in some patients, fibs cannot be recognized in requisite number. Remember, you must have seen patients diagnosis of ALS clinically okay, but when you want to demonstrate a denervation pattern, then you find that it is not fulfilling the criteria. And then in that case, we have to say, okay, we'll repeat it after some time, maybe 2-3 weeks or again, because sometimes if you want to make stringent criteria, then it sometimes does not fulfill. We must remember that fasciculations are as important as fibrillations. So if you are getting fasciculations, then you can keep them as a evidence of denervation for the diagnosis. So this is the latest criteria now, that fasciculation and fibrillations have same clinical importance electrophysiologically, and if you can see them clinically, it's okay. Okay. So in ALS, we have to see distal limb, mid-thoracic, lower thoracic, and do slit hand. Slit hand, Dr. Jayanti had already shown you, so I don't want to repeat it, but I'm going to discuss it in a different viewpoint. These are the summary. It's a very nice slide, you know. It summarizes all the findings, you know, of ALS. You can see fibrillations, positive sharp waves. You can see CRDs. You can see fasciculations. Yes, C is fasciculation. And then you can see decreased recruitment with increased firing rate is here. And you can even see decrement. You see what is happening, that motor units are innovating. So some of them are immature, so they may get fatigued. So you may get a decreasing pattern. The amplitude initially is high and later on it looks like a declining amplitude. Or you may get variation in motor unit sizes, you know. When you do EMG, sometimes it is coming very high and sometimes becoming low because of immature neuromuscular renovation, and therefore we can get these findings. When you do more of EMG, you will start seeing these things. This video is not coming. Can you help me with this video, sir? अच्छा देखो साउंड आ रही है, वीडियो नहीं है. हाँ ये आ गया, ठीक है. इसमें जाओ, इसमें स्लाइड में ही है. हाँ इसमें ही है, ये है. इसको हम बड़ा कर दें. इसी से प्ले कर दीजिए. बड़े में नहीं आ रहा है. नहीं हुआ. ठीक है, बाहर नहीं, ऐसे छोड़ को हटा दो, नो प्रॉब्लम. हाँ सर, इसको हाँ इसे दिखा दें. नहीं आ रहा है. स्लाइड शो कर दिया ना. स्लाइड नहीं आ रहा है स्लाइड शो में. हटा दो. एक साथ वो दिखाएंगे. चलो बाद में दिखा देंगे. Listen, ठीक है. Listen, don't worry. I am seeing it. You are seeing. Listen, this is not coming. You believe me. That's the very nice fibrillations which are coming. This is the paraspinal examination. and the patient has, I will show you again. So this is just a thing that, you know, you are seeing mid-thoracic, do in this position, and you can nicely see. I will show you again in a separate video if it works. Sensory conduction I'm not going to discuss in motor neuron disease because it is of theoretical importance. Only thing is that we can learn about excitability of anti-horn cells, of motor neurons. We can learn about the excitability by giving paired stimulation and how the interstimulus interval is changing and how the excitability is changing. It is theoretical at the moment, but what I'm saying is that it will help us to understand this disease and why it happens. I will come to it again. Suffices to say that we can learn about, through transcranial stimulation, we can learn about the excitability of motor neurons. Yeah. Okay. Now these are the yeah. So these are the diagnoses which you would like to rule out, like cervical spondylotic myelopathy or fluorosis. You know, these patients can present with cervical and lumbar compression, anti-horn cell involvement. You do all four limbs, you may get fibrillations and denervation, renervation and spasticity. So it may be confusing. So what we have to do is that we have to do paraspinal EMG to find out that if the diagnosis is motor neuron disease or not. Syringomyelia, I'll show you a case. Segmental SMA, of course, Dr. Jayanti has shown you. Kennedy syndrome, we will discuss. Multifocal motor neuropathy with conduction block, we have shown a case. And sometimes they can be long-standing weakness and wasting of a limb, and reflexes may be normal or brisk, and it may be confused with a motor neuron disease. But if you diagnose this condition, it may be therapeutically rewarding. Aji? We will talk in CIDP, but but those who will not come in CIDP can be benefited even now. Then paraproteinemia, inclusion body myositis, myasthenia, sometimes myasthenia patients also. Bulbar involvement, limb weakness, sometimes fasciculations seen, and you get confused with ALS. And it is disastrous to diagnose ALS in a patient who's got, and you do a decrement, you may get 20% decrement also. So then it will be very, skill is required and judgment is required not to diagnose an incurable disease. Go for myasthenia and see for a therapeutic trial rather than, Then thyroid, parathyroid myopathy, exosomal deficiency, and lead poisoning. Yeah, a treatable ALS is lead poisoning. We had one more case of bullet in the eye and thing which we had sometime presented, but otherwise we will discuss it. And then hereditary spastic paraplegia, again primary lateral sclerosis, hereditary spastic paraplegia. So we have to, of course, think of autonomic abnormalities, sensory abnormalities, think of dementia, and we have to think of diabetes and ulnar neuropathy, which may be coexisting and confusing an issue. So that judgment has to be made. Well, variant ALS disorders, we all, you all know that familial disorders are very rare, and it may be sometime with frontotemporal dementia or Parkinson dementia complex of Guam, and there are certain genetic disorders, but I'm not going to bother you with that. Spondylotic myelopathy, we all have seen cases, we all have, I remember one of my teachers in the respiratory department who presented with weakness in the upper limb and lower limb for spastic. He came and, he had a similar type of X-ray which showing compression. He was operated. After surgery, he did not improve. He went to England where they diagnosed ALS, and then he came back. So I think these errors are possible sometime, and you want to give a chance that instead of diagnosing ALS and missing compressive myelopathy is a little disastrous. So I think this is where a sensitive, a clear-cut EMG is required. If you demonstrate paraspinal muscles or bulbar involvement, then you are more sure of the diagnosis. The Syringomyelia was mentioned. Now we are diagnosing Syringomyelia much more easily because you do MRI and you see nice syringes, and you may have fasciculations, and sometimes it may be pure motor. Suspended sensory loss may not be present, and in that case, ALS comes as a possibility. And then you do the EMG, you will find renovation. But what is more important is to look for fibrillations. If there is a lot of wasting, you must have a lot of fibrillations. Whereas Syringomyelia, mainly you will see renovation and very little of fibrillation. So this judgment has to be again made, and of course the radiology will of course help people. Hirayama disease, I don't have to talk, and then the not talking Hirayama disease at all. And then Kennedy syndrome, we all have seen once in a while Vijay also mentioned about Kennedy syndrome. 62-year male was referred as ALS, tongue atrophy. He has shown very nice tongue atrophy, fasciculation, proximal limb weakness with spastic quadriparesis, limb and positive sharp waves in all 4 limbs, gynecomastia, diabetes, CK elevated, and he may have sensory abnormalities. They have normal survival or reasonably long survival, and respiratory failure is the cause of death. Multifocal conduction block neuropathy is seen. We all know that we have to stimulate and go more proximal and detect a conduction block. And if we can detect conduction block, maybe IVIG or plasmapheresis will help. Otherwise, they look very similar. There may be long history of weakness, usually in young people, hand and forearm over years. Cranial palsy is rare. Fasciculations are common. Tendon reflex may be reduced or increased. Sensations are normal, and proximal and lower limb involvement is less common, and then you can diagnose them with showing a conduction block. Myasthenia I have already said, and ALS patients, may also show decrement. 30% had more than 10% decrement. So we have to think that in a patient, we should be cautious, do antibodies, do prostate mean test, see for reversibility, and if that is there, myasthenia is much better diagnosis than ALS. But of course, one should not make a wrong diagnosis. That's very important. And of course, inclusion body myositis. We once in a while we'll have these type of weaknesses which are shown predominantly distal. They are pure motor, and CK is elevated, and then biopsy will be of help. Of course, in HIV patients, a reversible form of ALS-like syndrome has been reported. I have not seen, this is from literature, but we must keep in mind that HIV patients sometimes will have ALS-like syndrome, which is an unusual extension of HIV disease, and it responds to hard treatment, so we should keep in mind. And multiple myeloma can also present because of shoulder girdle fasciculations, upper motor neuron type of quadriparesis, and then you have an M band and you have osteolytic lesions in the skull, and we are able to diagnose these conditions. This is again a very interesting thing. And these children, you can see what is he doing is he's melting silver. So they mix silver and lead in equal amount and heat in this furnace. And usually it's a family trade, and quintals of silver is refined in chalk. Where you go, you will find these type of boys, and this is all lead fumes, and they developed abdominal colic. They call it lead colic, and one surgeon was very popular, and he used to open them up for cholecystectomy or acute abdomen, and it was very popular. And many of these were opened up and operated, and appendices removed. But actually, there were cases of lead poisoning, and some of them presented with wrist drop and foot drop, pure motor syndrome, may be confused with ALS like illness or pure motor neuropathy. So this is we have to keep, and once you curate them, they may have a potential of improvement. Another disease when I came to PGI was I did this study. It is laterism. You see, these are the lateris sativa plant, and these are the people with severe spasticity. I've never seen this degree of spasticity, lower limb spasticity, and you may confuse them with primary lateral sclerosis, but they all run in community. Large number of 19 patients I had called to PGI and did their conductions with the help of Mr. Bish, and these data were published, but they were never quoted because nobody is studying lead. But then they are a very interesting model of primary lateral sclerosis. Those who want to know about primary lateral sclerosis can see this type of neurolaterism cases. And of course, these are sclerosis cases. Again, you will see similar type of myelopathy because of the cervical compression, lumbar compression. They may be confused with thing, but then but you see interosseous membrane calcification, urinary fluoride high. So we can diagnose them. There is no difficulty and no confusion with ALS. But those who have not seen or expecting these conditions or are not aware of the epidemiology may be confused. So I think this is a flow chart which I try to make the pure motor weakness, do clinical examination, EDX, and then you will have a lower motor neuron or upper motor neuron or a combination. Then you rule out conduction block, look extrapyramidal symptoms, look bowel bladder involvement and eye movement abnormalities. And if they are not there, then you diagnose ALS, which may be primary lateral sclerosis, ALS, or progressive bulbar involvement, and the whole spectrum of ALS can be diagnosed in this way. Of course, we have to look for sensory neuropathy and gynecomastia, and in that case, we have to think of Kennedy syndrome also. So this is the bulbar and limb, lower motor involvement and upper motor neuron signs are highly suggestive of ALS. Electrodiagnosis helps in defining lower motor neuron involvement. Thoracic and paraspinal and tongue and masseter EMGs are helpful. EDX also helps in excluding other possibilities. Mimics and associations and variant disorders should be considered. Infectious, toxic, and neoplastic and treatable disorders should be carefully excluded. If in doubt, repeat the examination after a few weeks. Now, I will show you a case which is a 55-year-old male. He had walking and he had walking difficulty and wasting, mainly in hands for 1.5 years. Upper limb wasting and fasciculation, lower limb spasticity, sensations normal, hyperreflexia, classical case of ALS. Median nerve conduction 3.5, and median conduction normal, CMAP slightly reduced, perineal conduction again CMAP slightly reduced with 44 meters per second, and pseudoconductions nicely present. So the classical, but what I'm saying that these nerve conductions should be done before doing EMG examination. Now I will show you, these are unedited videos, so please excuse me if you not find them very neat, but then this is what it is. हाँ जी हाँ इससे नहीं जाएगा ना हाँ ये आएगी. Yes, sharp apes, yeah. Yes, now he's asked to activate. Sound is very polyphasic. Yes. Okay. So you can see poor recruitment, fast recruitment.
Poor interference.
So everyone is done. Now we go to APD. Sorry, APD. Yeah.
Better policy varies.
Better policies varies. Yes. Okay. Yeah. Thank you. Yes. CRD. Fibrillations, sharp waves, spontaneous activity. Now, these are NUPs, long duration. Sound will come. So this is up. Now we are going to tibialis anterior. Now tibialis anterior. It was said that they come easily. Yeah. So you can see, yes, these are motor units. Now, motor unit. Now, long duration polyphasic. Yeah, tibialis anterior. Yeah, fibrillation sharp wave also coming here. These are long duration polyphasic. Fibrillation sharp wave. Long duration. Okay. So yeah. These are okay long duration polyphasic polyphasic. Now we are doing gastrocnemius. Difficult muscle to do, but you are getting fibrillation sharp waves here. Yes. Yes, you are getting fibrillation sharp waves. Now we will do activation.
Fibrillation.
Regular fibrillations, yes. Sharp wave. Now motor units. Motor units. Poor recruitment, long duration, high amplitude. Now do paraspinal. Paraspinal, looking for spontaneous activity only. Sharp waves. These are fibrillations, sharp waves. Nicely coming. We don't look at motor units here. Now, again, again you are getting fibrillations, sharp waves are coming. Paraspinal. Lower paraspinal. Sometimes lower paraspinal is quite. Lower paraspinal. Now we are doing messenger. Now we are doing messenger. Mouth is open, you put the needle, and you get circulations. Circulations. That if we do the EMG and explain to the patient what we are going to do and take him in confidence, it is possible to finish the examination in about 5 to 7 minutes. And there may be some difficulties, you may not have a need recording, but then, you can make a diagnosis. So this is what I wanted to emphasize. Now, I want to give a closing comment, I'm quite interested in this problem, and everybody has talked to split hand syndrome, wasting. So I was reading about, ALS, and then it comes to the question that is it a antegrade degeneration or a retrograde degeneration? Where does the pathology begin? Does it begin in the cortex and go down, or does it begin in the antihorn cell neuromuscular junction or spinal cord and goes up and down? So that was the question. And with cortical stimulation techniques, I had referred that it may be because the problem may be that of antegrade degeneration. Mera slide change nahi hoga. Okay, so now you see, this is the most important thing you will notice, that it is the thumb muscle which are selectively affected in ALS. I mean, split hand index is very positive in ALS because thumb is mainly affected, selectively affected. And there are other clinical evidences that, ALS is not found in animal. There is no animal model for ALS. I searched, there is only one person who was doing an animal model for ALS by giving vitamin C. And when I wanted this technique for Dr. Babu, that person was no more, and this technique had stopped. So there's no nice animal model for ALS. And then, the muscles with corticomotor neuronal supply have is selective involvement. For example, ophthalmoplegia does not happen in these. Sphincters are relatively spared, whereas voluntary muscles are mainly affected. Why? Then pure lower motor neuron lesions are very, very rare. And I told you that primary muscle atrophy is extremely rare in ALS. Majority of cases probably involve the cortical and the spinal neurons. And then focal muscle involvement mainly occurs in APB and FDI. When you see a case of ALS, you will be struck by the early cases also. APB is affected, and this I had noted during my student days, and I used to always wonder why it is happening like this. And this is probably related to the cortical excitability. Human beings, when they have evolved, and number two, there is asymmetric limb involvement. First one side affected, and then the other side gets affected. Now, the most interesting thing is that there is a concordance between the dominance and the handedness. If you look at the large number of ALS cases have been seen, then it begins mainly with the dominant side. So the dominant side is hand is mainly more excitable, and there is no correlation with footedness of the patient. So this is again a very interesting finding. And therefore, it seems that the cortical excitability has an important role. And why the thumb? Thumb is related to the human evolution. Look at the thumb; it has become so evolved compared to the other species. You see the claws and other type of things, and look at the thumb of the human being. How efficient thumb and index finger. How nicely they have evolved that we can hold anything, we can manipulate anything, and do such fine movements. And of course, therefore, it is got a much larger cortical representation, and therefore greater excitability. And the human evolution has begun with when people started walking on 2 feet, and therefore what it is said is that they got hands for feet. Initially they were 4-footed animals, now they walk on 2 feet, and the hands are replacing the 2 front feet, and that's the most important. The bipedal walking evolved. And the most important thing was a position of thumb and index finger. This gives, and even the other digits, if you see, the index finger is a little shorter than the ring finger. And this is why that you can make a fist, and then you can use it as a weapon to punch anybody and to manipulate things and manipulate your food and manipulate your articles. So this is the most important thing. So therefore, thumb and the selective involvement of the thumb is related to probably the cortical excitability, and that is why the ALS begins mainly in the cortical neurons and then goes to other places. This is one of the thinking, and I think this is related to evolution. So ALS is a disease of evolved people. And thank you very much for your attention. Any